ah. His homework was to produce the sound on the horn, remove the horn, say the sound of ah, and feel what it felt like in his jaw, that low jaw sound. In addition to that, he was also working on a lip closure exercise involving a tongue depressor. What I would ask him to do is take the tongue depressor, put it between his lips, take it out, put it back a few times, and then on the last time, hold it between his lips and say the sound of mm. Mm. Take it out, mm. Take it out, mm. And each exercise had a criteria number of repetitions before you would work on production. The next week, when Scott came back for therapy, he wasn't in my waiting room, and I said to his mom, "Where is he?" And she said, "Well, he's already gone into your office. He has a message for you." When I walked into my room, his mom followed, and she had tears in her eyes, and I thought, oh no, they're moving, or I'm not going to get to continue working with this child. But instead, Scott had left me a message on my table, and it looked like this. He had 2 tongue depressors on the table and his horn right in the middle. And I said to him, "Scott, what is this?" And for the first time in his life, with me, he had done this at home, so Mom already knew that it was going to happen, but with me, he was able to say, Mom. And at that moment, I knew that oral motor therapy, muscle-based articulation therapy, has to be a part of a program for children with muscle deficits. Apraxia has a combination of motor planning and muscle weakness. Many of our clients have muscle weakness. Before I go on any further, I think it's important to make a comment because the field of oral motor therapy is just beginning to get recognition in our universities. There has been a misconception that people in this field of oral motor are trying to make the muscles of articulation super strong, like make them into bodybuilder. And that's not true. This therapy is designed to normalize the muscle. So you wouldn't be working beyond the skill of a typically developing 4-year-old. We're not trying to make the muscle stronger than normal. We're trying to make it adequate for speech. And that's going to be very, very important. Here's another example of an oral motor exercise that's part of a program that we use in our company, Talk Tools. If I take a bubble wand and I open it up, filled with bubbles, and I blow the bubbles like this, you might describe that as bubble blowing and say, well, what does that have to do with speech? Well, that's true. That has nothing to do with speech because it is not a coordinated movement. But let's look at bubble blowing again from a therapeutic model rather than something that is just something that a child will produce. In order to blow this bubble, I have to do a lot of things, and let me show you what they are. Therapeutic bubble blowing is grading in the abdominals, which creates adequate airflow for speech production. It is then grading in the muscles of the velum in order to push the velum back towards the pharyngeal wall so that air can go out of the mouth. It is an exercise in jaw stability. Jaw is very important to speech, which we will talk about in just a couple of moments. It is an exercise for lip rounding and an exercise for tongue retraction. All of these components of speech production. When a child has difficulty blowing bubbles because their tongue is too forward, we also see that their tongue is too forward for speech. So these non-speech activities are normalizing the muscle in a non-speech environment, and then it becomes the responsibility of the speech and language pathologist to transition that movement into speech. And each of our exercises ends with, how do you transition the movement that you have just taught into speech production? In this next section of exercise, we're going to be looking at what I believe to be the most important articulator for speech, and that is the jaw. This jaw musculature has been really, I believe, ignored in our profession. We look at lip action or tongue movement, and we frequently eliminate the importance of the jaw. I want you to try to experience something with me before I begin this. I want you to put your mouth in a slightly open position. For example, say ma, and keep your jaw in that open position, ma. Now, without moving your jaw, try to say an M sound. It's impossible. Jaw grading, the ability to go up and down in a controlled pattern or controlled manner, is what enables us to be able to initiate vowel and consonant production. When we think about the importance of the jaw, I think the best way to describe it is through a visual in the next slide. Pretend that you are going to the circus and that there are 3 acrobats on the bottom, 2 in the middle, and 1 in the top. And the acrobat on the top is the most controlled and most organized and most highly qualified athlete in the whole universe. Well, if that athlete is on the top of that pyramid, but the 3 acrobats on the bottom are moving around a lot, what is going to happen to that athlete? He's going to fall. Well, in the same way, I want you to now look at the words that go along with those different levels of the acrobatic triangle. If the jaw is not strong and stable enough to support the independent movements of the lips and the tongue, there is no way that you can have normal speech clarity. What we've done at Talk Tools is developed a program that addresses each level of the 6 jaw grades or jaw heights that are necessary for speech. For example, an M would be a high grade and you would work using a very narrow bite block. An Ah, which is a much wider grade, you would be using a wide bite block. And these exercises, there are 3 at each level, at each bite block, these exercises are designed to normalize jaw skills. Once we look at jaw skills through a diagnostic approach involving bite blocks, or in many cases for children who are younger and cannot follow directions that would be needed for bite blocks, we can use assessment tools like grabbers. And this is all a part of a program that is called the Assessment and Treatment of the Jaw, which has exercises listed and instructions on how to perform the activities, how to do the diagnostic, and how to then create a therapy plan to normalize muscle movement. I think what is so critically important about our company is that everything that we teach comes with directions. Our goal is to teach a technique. The therapy tools are there to implement the tactile component of that particular task. The next hierarchy is the straw hierarchy, and fortunately this didn't take me quite as long as it took me to develop the horn hierarchy. The horn hierarchy took about 8 to 10 years to develop because you were looking at all those different components of movement that we discussed. Straws were a little bit easier. What I was looking at for a straw hierarchy was the ability to grade the muscle movements in the tongue. If you look at the next slide, you're going to see that the tongue is divided into 8 areas. And each one of these areas has to have adequate strength and skill in order to work for speech. For example, as you're looking at this slide, envision that you're asking your client to say the sound of the letter S. Well, to produce the sound of the letter S, you would have to retract the positions 1, 2, 3, and 4 in the tongue. You would have to protrude or elongate the positions in the front, 5, 6, and 7, and then you would have to tighten position 7, which is the tongue tip, either in an upward position, a down position, or a medium position. In order to be able to perform those activities, you have to have skills at each one of those graded positions. In the straw hierarchy, straw number 1, which is the easiest to use, only requires the back of the tongue to retract a small amount. So therefore,